more grand rounds talk from our own Dr. Cimino, who's going to be leaving us pretty soon, and Dr. Scott from the Emergency Medicine Department. So I'll go ahead and introduce them before they get started. So Dr. Cimino, as most of you know, is an assistant professor in the Department of Family Medicine at USU. She graduated from the University of Southern California, Keck School of Medicine, did her family medicine training at the Naval Hospital, Jacksonville in Florida. She was stationed in Yokosuka, Japan, and then went on deployment to Kandahar, Afghanistan. She then went to Naval Hospital, Bremerton, as a faculty and associate program director. Following that, she served 3 years at the White House Medical Unit as a director of clinical services and the lead physician for the Presidential Support Duty Program in Executive Medicine. She then joined USU in 2017 and has been the director for RP, Reflective Practice Curriculum, as well as Executive Curriculum Committee on the Curriculum Integration Subcommittee. And sadly, she'll be leaving us shortly to go to Fort Belvoir as the residency program director there. Dr. Cimino is also on the board of directors for the Uniformed Services Academy of Family Physicians. Dr. Scott is an assistant professor in the Department of Military and Emergency Medicine. He did his dietetic internship and Masters of Science in Clinical Nutrition from the Ohio State University and PhD in Health and Rehabilitation Sciences from the Ohio State University as well. He did advanced training in sports nutrition and has distinction in the board of certified specialist in sports dietetics. He was a sports dietitian at the Ohio State University and also did some contract performance. He was also a contract performance dietitian and later a senior scientist at the Henry Jackson Foundation, supporting the Consortium of Health and Military Performance. So I welcome both Dr. Cimino and Dr. Scott.
All right. We're on. Winnie, we're good? All right.
Yes, go ahead.
Okay. Well, thank you for joining us today for this Grand Rounds presentation. I promise you this will be some of the most fun you've had listening to a lecture in a while, partly because we are talking about food. And so I do hope you have lunch, because even if you aren't hungry right now, you probably will be by the end of it. Dr. Scott and I had a lot of fun putting this presentation together, and you will find that we are going to do a little bit of interaction. So we'll punch you into some breakout rooms for a few minutes and regale you with lots and lots and lots of food puns. So that's been some of the most fun. That's one of the reasons that this curriculum has been fun to talk about, and one of the reasons that we're presenting it to you today as Turning Up the Heat, a primer and a plea for teaching nutrition in UME and GME. And before we get in too far, we'd both like to note that this conversation wouldn't really be at the stage that it is now without the initial interest and idea for the Culinary Lab that really was Dean Pox. Her enthusiasm and position enabled a small group of enthusiastic parties, which included Dr. Scott and I, and Dr. Chang, Dr. Emmerich, and Dr. Whitkop initially, and Dr. Rittenhouse, to continue to refine and expand this experiential nutrition education here at USU. And because she allowed for that sort of taste test of a different way of teaching nutrition, Dr. Scott and I have this to share with you. So without further delay, hold on, except for my awesome ability to manipulate these slides. Okay, there we go.
All right, great. Well, hello everyone. Yes, Dr. Remy, I'm still trying to hold it together after Monday's throttling, but in the interest of time, we'll move on. So thank you for the nice introduction. Really excited to be here today. As you can see, our objectives are fourfold. First, we want to examine what nutrition education currently looks like at USU. Next, we will recognize the value of interprofessional collaboration. Third, we will describe 2 programs that focus on nutrition education that we have adopted. And last, we'll discuss how best to integrate these conversations around food and nutrition across the educational continuum. So like any good Grand Rounds presentation, let's start with a case. This will give you a taste of the types of questions that are asked and discussed during our Health Meets Food Culinary Medicine module. This particular example is a nice throwback to the biochemistry lessons learned during pre-clerkship with a tie-in to the clerkship piece through a practical application. The case forces the learner and the facilitators really to take a step back and think about how we dialogue with our patients. So in this case, we have a 39-year-old female that presents to your office concerned about some of the juice boxes her son is getting at school after he brought one home. She notices that there's high fructose corn syrup listed in the ingredients. Her son is 7 years old and slightly overweight according to the BMI charts. She feels that high fructose corn syrup is a cause for her son's BMI, his increase in his BMI. Which of the following is true of fructose metabolism? So you can read the potential answers there. What we'd like you to discuss are what are some other foods that are high in fructose, and is the concern really around high fructose corn syrup necessary? So what we're going to do is we're going to use the breakout room feature. You're going to be put in breakout rooms automatically. You'll just accept the invitation when it comes up. We'll have 5 minutes to discuss, and then we'll bring it back and talk about these things as a group. I'm also going to place into the chat feature the questions we want you to be thinking about, so you have those as you move into the breakout rooms. So I'm going to automatically create the breakout rooms now. Again, just accept the invitation when it pops up, and I'll have it set up so it automatically will bring you back to the main room once our time is over.
Back into the big Grand Round session. So we hope you had a few minutes to kind of chit chat about what is the actual answer to the question, and what is the topic for discussion. So I'm curious for those of you who are in the small groups to just talk about what you discussed. What do you think the answer to the question is, and where do you think that this belongs in terms of teaching it?
Okay, well, I will go.
Thanks, Heather.
So our discussion was more about counseling on nutrition in general and trying to steer people towards healthy balance. And I think most of us kind of said that we don't specifically talk about high fructose corn syrup unless it comes up, but talk about added sugar for sure, and added, any additives. So I think that's where we were.
Terrific. Yeah. And I think that's largely where we are when we're talking about nutrition with our patients. We're not necessarily talking about the micronutrients or specific vitamins all the time, but sort of general principles. Any other thoughts or comments?
I kind of go with the theme of like balance, right? So if your child is going to have a juice box, I don't want the child or the parent to have guilt about giving them a juice box, but really balance it with a good balance of water, as well as the theory of eat the fruit, don't drink it, to try to help kind of give them some buzzwords to think about versus getting in the minutia, which sometimes can be overwhelming.
Yeah, and I think we use this question for a number of reasons, and I think you highlight that well. That it's an opportunity to talk to patients about general principles, meet them where they are, debunk myths. And if you're the student looking at this case, I mean, it's also kind of a throwback in this particular case to some biochemistry. So dusting off those cobwebs of some biochemistry, which we'll get to later why that has been useful as we've implemented this part of the curriculum. But I do wonder if and you could just kind of ponder about this, if you think it's important for our medical students to be able to answer these questions for patients, or do you think it's really a better place at the residency level, or do you think it's really something that sort of gets honed as we go further in our careers? So just munch on that for a little while. Sorry, that was definitely a food pun. And we're going to move on from here.
Okay, so quick flashback. Speaking of biochemistry, this may be what you recall as your exposure to nutrition during UME, but before our sympathetic response gets too ramped up, let's move on.
No more Krebs cycle, please. Okay, so I will apply dietetic measures for the benefit of the sick according to my ability and judgment. I will keep them from harm and injustice. This is the actual quote from Hippocrates, which we often hear as "let food be thy medicine." So it's a misquote of that statement for sure. But I think it is quoted in that way because food has been around for as long, of course, as people and life has existed on this earth. And it was the original medicine. So where is this in the conversations that we're having with patients? Where is this in how we're talking to students about prevention and disease management and residents as they go further along in their training?
So using the chat feature, just a little food for thought. Answer the following question. What is one thing you buy every time you go to the grocery store? Milk, fruit, eggs, milk, apples, Diet Pepsi. As simple as this question may sound, it's really nice because it begins to bring this conversation back to food rather than nutrients. Because interesting, I didn't see anybody put in vitamin D, potassium, monounsaturated fat, soluble fiber. So this can be a really easy way to open up the conversation about nutrition with your patients. It's very low threat and also can be very telling. So again, a nice way to begin to have that conversation around food and nutrition. So if we go to the next slide then, and of course, sorry, not to remiss the baby on the slide that had destroyed their beats. Thank you, Dr. Cimino, for providing that great photo. We were going to do a who wears it better, as we actually found out that I had a picture of my son in almost the same look. But so let's look at a brief evolution of nutrition education as we think about it in medical training. So really the 1900s, the discovery of vitamins, basic nutrient requirements, really a widespread of nutrition principles in medical school. Some might even deem it the golden age of nutrition education. In 1940, we really transitioned and shifted to this, the molecular basis of nutrition, subcellular functions. The perceived importance in nutrition has really declined. 1937, Hans Krebs first demonstrated the existence of the cycle of chemical reactions. So really, again, the Krebs cycle is gaining speed and gaining momentum. And it's really then as we transition into the 80s, when we think about this prevention and public health notion, as we focus again, really on emerging epidemiological and clinical data that begins to link nutrition to the etiology and prevention of disease. Some of our major guidelines are being put forth in that time. The original dietary guidelines document is released in 1980s and has subsequently been released every 5 years since, to include most recently and on the 29th of December of 2020, the most recent version of dietary guidelines. And then we transition into 2010s, where now we're transitioning into this notion of food first, the focus really being on food rather than nutrients, as we talked about on the other page. And that was also reiterated in the most recent version of the dietary guidelines. We've really gone away from this notion of percentage of particular macronutrients, and we're having this discussion around food and food patterning across ages, across genders, across races, across various socioeconomic statuses. So it becomes an imperative conversation. Really, our future as we move forward, the way that I see it is this notion of precision nutrition, which seeks to develop effective approaches based on the combination of an individual's genetic, environmental, and lifestyle factors. And in fact, NIH just hosted a 2-day workshop on Monday and Tuesday to discuss this very notion of precision nutrition and how we're going to move the ball forward in the future. Next slide, please.
So we're sort of building a case here for why we should be spending more time doing nutrition education at all levels of medical education. This chart is a depiction of the most reversible causes of death in this country. This depiction is from 2014, looking back at the 5 years prior to that. But a follow-up article in The Lancet in 2019 reaffirmed these findings. And when they looked at dietary consumption patterns across 195 countries, they found that the improvement of diet alone could potentially prevent 1 in every 5 deaths globally. And what are these diseases that we're looking at? They are the diseases of the heart, cancer, chronic lower respiratory diseases, cerebrovascular disease, and unintentional death, accidental death. And so at least 3 of those have modifiable risk factors, which include tobacco use, high blood pressure, high cholesterol, type 2 diabetes, poor diet alone, and being overweight and lack of physical activity. So clearly something that we can intervene on. The American Heart Association has certainly tried to help tackle this with their Life Simple 7. We've heard Dr. Remy present this before, but you know, what are the Life Simple 7? They're eat better, lose weight, exercise, don't smoke, manage your blood pressure, decrease your cholesterol, and manage your diabetes or don't get it at all. Manage your blood sugar. So when you look at this, 5 of these 7 are directly or indirectly related to diet. So why are we not spending more of our time and effort understanding how to talk to helping our students and our residents and our doctors talk to our patients about these changes that they can make, which potentially could impact the reversible causes of death? But you might be thinking, you know, what's the big deal? Why do physicians need to know this? I mean, don't we have nutritionists for this? Dr. Scott is an amazing expert in this area. And yes, it is true that our nutrition colleagues are invaluable and can do more in the hour visits that they have with patients, half an hour to hour visits they have, than we may be able to do in the slice of the time that we're using in our office visits. But we have to get patients to go, and they're right in front of you and they trust you. And so it's similar to the way we feel about smoking. Just mentioning quitting increases the likelihood of change. And the same is true for nutrition advice. And they've shown this multiple times through multiple research studies. So these numbers, so 5. So respondents in a recent study showed that most physicians spend less than 5 minutes on less than 40% of their patients, if at all, talking about nutrition. They wanted to spend more time. And if they did spend a little bit more time, and we're not talking about half the visit, we're talking maybe 5 to 8 minutes, they were more likely to use supplemental material and more likely to have some follow-up for these issues. 75% cite the importance of both practicing physicians and medical students in knowing how to do this, but also significant barriers, including confidence with counseling, lack of knowledge, lack of support, and sometimes the perceived idea that their interactions aren't going to change patients' behavior. And then 24. 24 is the number of hours that the National Academy of Sciences recommends that undergraduate medical education spends on nutrition education. At the time it was published, less than 20% of schools were actually meeting that mark. And at the time when we first started this venture, USU was only at 6 hours of nutrition education. Some of that has changed since we've expanded our modules, both through the Culinary Lab, through some changes in the GI module, and through adding the Gaples curriculum to our clerkship. So we have definitely increased our number, but we're actually not at 24 hours either at this point.
So stirring the pot, some controversies and confusions around nutrition. This is just a brief pictorial summary of the federal nutrition guidelines throughout the last 80 years, from the basic 7 that was first introduced in the 1940s, when, as you might notice, group number 7, butter, has its own group, until we transitioned to the basic 4 in the 50s through the 70s, and introduced this concept of a food guide pyramid in the early 90s. And then most recently, in what is still our most current and recent iteration of our dietary guidelines, is this notion of choose my plate. But regardless of the model, there has consistently been a lack of confidence in nutrition and education amongst medical students. And this even pertains to our federal nutrition guidelines. So as we transition then and think about the various diet books that we have out there. So if we thought the recommendations from the federal government were confusing, we're constantly inundated with any number of diet books, which generally contradict our federal nutrition guidelines, of which all of the authors seem to make a compelling case as to why their solution is really the answer and why the government has really gotten it wrong all along. To further muddy the waters, as you can see, most of these are written by doctors, either physicians or PhDs. So how do we even begin to wade through this conversation? Here's some interesting food for thought. An estimated 45 million Americans go on a diet each year and spend $33 billion on weight loss products. Yet, according to the most recent reports from the CDC, 75% of US adults are overweight or have obesity. So that being said, let's take a step back and think about perhaps our first exposure to nutrition and cooking.
Okay, we're going to ask you again to use the chat feature to comment on what your favorite spice is. Dr. Scott, you're going to have to moderate that for me.
Yep.
This is my favorite Swedish chef. This is really our first exposure to cooking, right? Everybody's first exposure.
We've got pepper, garlic, a nod to bacon grease. We'll consider that a spice for all intensive purposes. You definitely don't want to throw that away. That's what the tin can's for in your refrigerator. Rosemary, cinnamon, cumin, coriander, garlic, garam masala. Nice. A lot of nods to pepper in this group, and cinnamon, rosemary. Nice.
Love it. We love using this icebreaker with the students. Partly, and you know, we find that there's a lot of garlic lovers, so love that, and lots of spice blend lovers too. But it's another way to open conversation around cooking and nutrition, and also the opportunity to talk about cultural preferences and family preferences, all of which are critical in understanding how to meet our patients where they are in regard to nutrition change. So does it need to be experiential? So great question. What's the angle, right? So why not just do amazing dynamic presentations like the one that you're hearing now, right? So how is this not going to make you a better counselor? Of course, getting more information through lecture is definitely going to help. And honestly, the refreshers help lots of people. Even doing a case-based series could be useful. But the experiential part here is the cooking, and it's a win-win all around, right? It's food and eating, but there's also pieces that I think, as we thought about it further, are a little harder to crack. It's a demonstration of things that are a little harder to crack in med school in terms of hidden curriculum. So things like the fact that cooking is low risk but high reward. I mean, we ask the students to take risks all the time, but they're often in a place where it doesn't feel like it's low risk. And in this situation, I mean, even if it goes horribly awry, it still was probably fine, and you probably ate it anyway. And so a chance for them to demonstrate risk and fail without significant consequences, but to work through challenges and limitations, and maybe work around recipes that have things that are required that they don't have, and so trying to work through substitutes, etc. Thinking about culinary literacy and access to food and equipment that you might need, or maybe you don't have, and so you have to work around that. And the growth happens as part of that being able to share and reflect. The other thing to remember here is that we are our first patients, and the the overwhelming research, and we'll talk a little bit about sort of the pie in the sky research of, does this format of teaching nutrition education translate into better patient outcomes, right? That's a hard link to make. And this way of teaching nutrition education is really about less than 10 years old. So some of that stuff has not been really shown yet as distinctly. But what we do know is that you make medical students healthier, and you make the people who are taking it healthier. And multiple studies have shown that when you make physicians, any kind of medical trainee or physician or clinician healthier, whether it's through diet or whether it's through exercise, they then counsel their patients more. So that link has been made over and over again. And so that is part of the reason to consider doing this in a more intentional way. And then the other thing to remember here is that we are living in a health system that is entirely reactive. As most of the people on this call are family physicians or family nurse practitioners, and we know that we do disease management, disease expectation based, so is our medical education. So if we want to change medical education to be more proactive, we have to focus on prevention, and it really starts with the food that we're putting in our mouths. So then how do we do that?
So we considered many models. The model from the cute babies to the Iron Chef, to the Naked Chef, to the Master Chef, and everything in between. And at the end of the day, we ultimately settled on this type of experience. We ultimately settled on the B3 Culinary Lab was our first real introduction to this. This was an experiential session for third-year students based off the University of Rochester version that such inspired Dean Pock to take this initiative and move it forward. Students were assigned to one of 6 cases, and they were paired with both a clinician and a dietitian. Last year, actually right before COVID, we were able to get our 2020 session in, and it was a great collaborative effort between the School of Medicine, GSN, Fort Belvoir, and Walter Reed. Students then discuss a case while preparing a healthier version of a recipe related to the case. The students have the opportunity to taste test and vote on their favorite dish, and then the winners receive the coveted USU Master Chef apron. Interesting, we've used the same 6 recipes the past 3 years, and every year a different recipe has won. So that's been kind of fun. And with some support from some seed money, we were able to purchase all of the equipment to essentially take our show on the road without needing a cafeteria or the USU's cafeteria, who has been extremely supportive of our efforts and our endeavors. But if we're thinking about bringing this out into the community, we had to think outside the box a little bit as far as how we would be able to execute and implement that. That being said, it can be labor intensive. It definitely requires sinks and places to be able to wash hands, and a decent amount of pre-prepped food, as you can see in the visual up above the table, that we have the pre-prepped food such that we can create and finish cooking all of the recipes within the 2-hour time allotment that we currently have.
So then COVID came along and made the idea of in-person experiential anything go away. But right before that happened, again, so helpful. Dr. Wickhop and I had actually had a chance to go meet with the developer of the Health Meets Food curriculum, who was originally from Tulane University and is now actually at GW creating a culinary medicine center right down the road. And he was doing teaching of faculty classes, and we had a chance to sort of do the same thing that we do in our B3 lab on his scale. And it is labor intensive, and it certainly requires a place to cook if you're going to do it in person, which we could not do as soon as COVID happened. But it did give us the opportunity to purchase the curriculum, which was an institutional license, probably one of the best deals, I think, in medical education in terms of cost per person. And we immediately began implementing this. We've run it as a 2 or 4 week course for anywhere between, I think the biggest group we had was 24, or actually I think the first group was closer to 30, and as small as 5 over the course of the last 6 months. This curriculum was first piloted at Tulane, and it's been adopted by over 55 medical schools. And we are going to sound like proponents of health meets food, but it's not the only curriculum out there. It's just the most well prepped, and it is the one that we were able to purchase quickly. But just to point out, the modules cover anything from Mediterranean diet to weight management, fats, food allergies, proteins, vegetarian diets, sodium, potassium, and hypertension, carbohydrates, and actually what's become our favorite module, which is mindfulness and motivational interviewing. And we have the students do those first eight blocks. What you see here is what we started with, a case. There's a series of lecture materials and cases and exercise questions. And then there's recipes that go along with each module. And what this did was it asked the students to be asynchronous in terms of their cooking. We couldn't have them all cook together. We also couldn't get on a Zoom call and try to cook together simultaneously in our kitchens, not with our students and God knows where, with who knows what kind of cooking equipment available to them. But it was actually wildly successful. And we were able to, I think, meet these objectives without having to do what is otherwise really fun to do in person, but also labor and material intensive.
So as mentioned, the mindfulness is one of the core components that we discuss. And one way to have the conversation about that is having the students take pictures of what they prepared. And the pictures just represent a very small snapshot of the recipes that they were able to prepare in a variety of locations and settings, whether it was home or in a hotel room where they only had access to maybe a microwave and stovetop, or as we've learned from some of our students, the value of the waffle iron, or even the iron that's in a hotel room, and really how versatile these things can be, but really forcing the stretch and making these recipes still look delicious and taste delicious also.
This is a picture of our very own Carrie Gibbons, who recently matched with Naval Hospital Camp Pendleton Family Medicine, showing off her resourcefulness during an ROM. She's in her hotel room. She had bought these materials before we got going, and there she is making some delicious looking taco bowls.
Yeah, so students not only complete the course, but have really flourished and challenged themselves to make personal changes, especially in situations where there's limited access or availability to cooking equipment and or food. What we find is this personal exploration really helps to further empower and reinforce the importance of proper nutrition, while giving the students a greater appreciation for the various challenges that their patients may encounter. And now that the students are able to share personal tips and best experiences as far as really how to overcome these barriers, has been one of the most exciting and gratifying parts of being able to be part of this great curriculum.
So let's talk about GME for a second, because there's lots of things that we can do creatively at UME, but how does this really fit at the GME level? And sort of what's the requirement for it, I think? I was certainly interested in that given my upcoming role change here. So I did a little digging and looked through the family medicine residency competencies, looking through the milestones, looking through whatever document I could find that might have had the word nutrition in it. The competencies that got closest were these, and so you can see some of the verbiage there. I think the one that's the closest to encompassing where we might fit nutrition education here and prevention overall is this: assess community, environmental, and family influences on health of patients. Because that kind of gets to some of what we're talking about in terms of going back to the beginning and talking about food as a marker for health. What I did find very encouraging is that the AAFP has created a whole set of a whole nutrition curriculum that's ready to go. So if you're looking for what kinds of skills or attitudes or competencies you want to have if you're trying to build a nutrition curriculum, they're already set up for you. It doesn't tell you how to do it. It doesn't have a lecture series. It doesn't give you the sort of the framework, like for example, the Health Meets Food curriculum does, but it does tell you sort of what your targets are, which I think are useful. So understanding general principles of nutrition, performing comprehensive nutritional assessments, counseling patients with a culturally sensitive manner, which we talk about again and again as we're talking through food recommendations for patients around whatever condition they have. It's really hard to tell somebody who's grown up in a culture where they eat rice every day and with every meal, that you suddenly can't have rice. It's just not going to work. It's not going to be sustainable. So we have to meet patients where they are, and this is a way to learn that. So this was reassuring to find. I went looking through the RRC requirements to see if there was something there, and actually it comes up in the framework of wellness and fatigue management for both the faculty and the residents. And so as you can see here, in terms of well-being including having time away from work and attending to personal needs for one's own health, including rest, healthy diet, and regular exercise. So certainly this kind of curriculum helps meet some of those markers. And then fatigue management, which includes, as part of that fatigue management, maintaining a healthy diet. So how are we helping our residents maintain healthy diets and learning about what that actually healthy diet needs to look like? I remember talking to my mom during medical school and residency about like trying to get healthy food. And she said, you know, Frankie, you might just have to go get frozen meals that, Healthy Choice or something. I mean, they have a lot of sodium, but at least you're getting vegetables and a mix, a balanced meal if you can't just eat, create something every time you try to go to work. So, I mean, even things like that, I think are helpful tips when you're trying to eat healthy in residency. EPAs are still a little bit intermittently adopted amongst family medicine programs, but there is one that talks about preventive care that improves wellness, modifies risk factors for illness and injury, and detects illness in early treatable stages, which I think nutrition curriculum fits right under in terms of ways to meet this EPA. And then just finally, I went looking for this in other subspecialties, so who else needs to care about this, right? Outside of family medicine and the generalists. So I looked at sports medicine, and there's a nod to nutrition there, but in terms of knowing basic nutrition principles and their application to exercise. The gastroenterology fellows need to know about nutritional disorders and about nutrition as applied to GI disorders. Again, neither group is really looking at sort of nutrition as applied to general health. And then cardiology, to be a cardiologist and take care of the most preventable cause of death, there is not a mention of needing to know anything about nutrition, which I still find to be a huge shame. Okay, and so while experiential nutrition education is very appropriate, in our opinion, at the UME level, its application at the GME level is undeniable, because teaching principles of nutrition in this way incorporates motivational interviewing, which they can practice on a regular basis, behavior change principles, and principles of around social determinants of health, including implicit bias, discussing economic influences, food deserts, and disparities when it comes to nutrition, and how those disparities around nutrition also lead to disease and illness in certain communities. And I think the residents are at a place where they're applying that far more frequently than the undergraduates are. And so I submit that this is a place we should be focusing on in terms of being better about nutrition education at that level. Okay, so let's take a minute and talk about it. I'm sure now you are now hungry. Given all of these issues that we've discussed, let's brainstorm some ways to incorporate nutrition ed in whatever stage or platform you're responsible for. We were going to send you into breakout rooms, but I think it might be actually more time efficient and give us some more time for questions if we do that together. So if you are willing to maybe think about this out loud, I'd love to hear your thoughts about where you think this could be incorporated at whatever stage that you're at, and how you feel about it so far.
Hey, Frankie, this is Matt Flipson. How you doing? No, I thought this is great. I think the focus on cooking is a good one. Typically in clinic, you don't have a lot of time with the patient. And so I try to hit home, like getting a quick assessment of, okay, what are you eating and how are you eating? I think is a good way to start. And often you find that most people are not cooking themselves. And so trying to find a way to encourage them to do that. It brings to mind a recent patient I had who I set a goal for him. I said, hey, there's lots of cooking videos out there, right? On YouTube, etc. Pick one recipe a week and try a different recipe a week. That was a good starting spot because he wasn't cooking at all and he wasn't comfortable with it. So I think, and then having him follow up and holding him accountable to doing it, talking about what he made and then coming up with some more goals the next time. So I like your idea of focusing on cooking, and that's been a way I've been able to incorporate that into my patient encounter.
I love that. That's a great patient challenge there. I have not had a chance to use that one yet, but I will. Dr. Survey?
Yeah, when you ask me how I incorporate this, I think in my daily life doing faculty development, we added this with our Health Disparities Journal Club because it really got faculty thinking about why does something happen, and it forced us to go back to kind of the 5 whys. Why do they have a higher incidence? And nutrition, economic status, other resources, transportation all came about it in that regard. And that's been pretty eye-opening to me over the past 6 months as I've been doing that.
I appreciate that. And I think that the more we've had this conversation about nutrition, the wider that aperture is on those disparities and who has access to healthy food and how to help people get there. Dr. Remy.
So while it's not a new idea, Frankie, you and Jonathan already talked about it, but I think one of the most important things we've done so far, but the battle is not over, is make sure that in building F, there's actually quite a few places for kitchens and culinary labs, so that this becomes a much easier lift in terms of students being able to go there, whether to cook for themselves or whether to do it as part of an academic program, to make this sort of a more routine part of our program. So I think in the future, it's making sure that that continues and that resources are brought to bear on that. Because I do think what both of you said, that students who learn how to cook for themselves become much better educators of patients in the future.
I look forward to seeing that come to fruition, I think, because it's really been in other places where this has been more advanced, Tulane, for example, and I'll share this in a few minutes. I mean, they have shown that when students are involved in teaching those community classes, they have a lot of community engagement, and then they have better health outcomes for their patients. And so that is, you know, sort of the ultimate bottom line. We shouldn't be doing this because it tastes good, although it does, but because it actually changes our patients and makes us healthier. So we'll come back to a little bit more here at the end. We'll have a little bit more time for questions here at the end. And I do want to say before I move to the next slide that, you know, we did also incorporate the Gaples Nutrition Education course, which was a 4-hour self-paced module that we were able to purchase before we were really able to get this going, to let all clerkship students have a basic understanding that was still written in this kind of way, that's still written in the sort of general principles of nutrition education and in early nutritional assessment, and a little note about motivational interviewing. And so even at that 4 hours, in a cursory look that we looked at when we looked at the differences in how people counseled their patients at an OSCE, we saw a difference in how they and what kinds of things they tackled in that OSCE around nutrition and health habits than the students who hadn't had it. So I think that even just doing that tiny intervention may have made a difference. And this is the next step. Okay, hold on. There we go. Did it change the slide? There we go. Okay.
And as mentioned, here's our next step. Here's our very own Megan Plunkett, who recently matched with the Eklund Family Medicine program, taking her passion in cooking and turning it into a resource originally intended for her classmates as titled Cooking and Clerkship, but really a resource for all in how to be resourceful when you're really limited with either cooking equipment, time, financial resources, etc., and really creating, again, just an invaluable resource, open access for everybody to be able to use. We did note too that she looks a little too happy holding that chef's knife, so we're happy she went into a family medicine versus a surgical residency. But let's take a quick look for maybe just a minute or two at our cooking and clerkship site for those of you who may not be familiar with it. Okay, hold on, let me click on that real quick. So this is her veggie. Can you see my screen? Can you guys see this slide? Okay, so you can see her veggie pasta here.
looks delicious. I mean, budding food photographer as well. And if you scroll down here, she's got the ingredients, the directions for cooking. And then she also, I mean, I think the thing about Megan's site that's really wonderful is that she's talking about how to do it in your hotel room or with minimal cooking utensils. So I didn't even know you could do some of these things, frankly. Microwave your pasta, microwave the vegetables, the way she uses a waffle iron. I mean, these things that I just never knew you could do. She's got lots of things here to help you understand what other ways you can use your limited resources. So that's, it's worth looking at later if you haven't had a chance to look at her site yet. Okay, hold on a second. Oh, I gotta go back. Oh, no. Sorry, I'm trying to get this thing to collapse. Hold on one second. It's not letting me move my screen. I just have a couple more slides. Okay. Are we back? We're back, right? We're back. Okay. Okay, and so just a nod to what really is the pie in the sky, right? So is teaching nutrition to patients going to change their health outcomes? And so there's, since Tulane really is the first place where they had this culinary opportunity for the community, that's where the studies are coming out of. And so, you know, while it wasn't a big initial look at in terms of numbers of patients, it was under 30 patients. They did a randomized control on 30 patients and looked at the people who had participated in this program and those who had sort of standard nutrition counseling, and they had better outcomes in A1C, in cholesterol, in diastolic blood pressure, albeit small sample size. This kind of study is very hard to do, labor intensive, obviously correlational and not causational, but that is where you hope that it's going. And I don't know if we need to get right now to the point where we're always cooking with our patients, although I think we're going to get there, especially if we have the opportunity in places like the future Building F, where we're able to do that. But starting with our clinicians is really the place where we can get the most bang for the buck, I think.
Really, in summary, the combination of the Culinary Lab, the Health Meets Food Culinary Medicine curriculum program really both represent novel approaches to nutrition education at USU and delivers high quality, evidence-based, interdisciplinary, and an interactive experience. We can deliver nutrition lectures and expect medical students to remember information for a test, but if we teach our future physicians to cook, we will cultivate their interest and confidence in both counseling with their patients and also modeling healthy dietary habits for a lifetime. So so two things. One is, the other thing I think we need to be very explicit about is that this curriculum that we've been doing for the last year or so, I mean, how long have we been in COVID? About that long, has been entirely interdisciplinary. So Dr. Scott, Dr. Rittenhouse, myself, Dr. Chang, I am pediatrics, emergency medicine. We've had physicians from all over the country drop in to help us teach this, partly because it's not rocket science. This is very attainable stuff, and it's all stuff that we know generally, and also because we cook in our lives. You know, so all of these things are things that are not inaccessible to us as clinicians and people who've been talking to patients for a long time. So I love that part of that, and I love that we have had a wide variety of perspectives come and share these experiences, both in the kitchen and with nutrition and talking to patients when we've been teaching this to our medical students. We do have another 2-week Health Meets Food elective coming up. And so if you have some time between the 2nd and 12th of February, we're basically doing it 2-hour sessions on those Tuesdays and Fridays. Would love to have your involvement. And I'll just add this too. We did have one iteration over the summer where we and had some of our colleagues from the GSN join us in this interactive experience, and that was great, given some of the operational experience that the GSN students bring to the table. It really was a nice dialogue and perspective that they brought that, again, just really facilitated and went right in with what our students are learning then as well. So see that as a way of expanding out in the future too.
All right, and that concludes our awesome presentation with a ton of food puns. Honey, do or do not do. There is no try. Baby Yoda at his best. happy to take questions, thoughts, comments.
This was an excellent talk and overview about where we are as the status of nutrition as we look at it as really a prescription for health. One particular lens that I like to use is the origin of food, and particularly when it comes to children. So getting them to just put a tomato plant in a pot, and they often like to eat what they grow. And it's simple to do, and you don't have to have a green thumb. So, those little things can be helpful to encourage families, even residents, even faculty to say, hey, try growing it. And you don't have to go to the store. You bridge that cost gap because a plant can cost $2, and you get them to add a layer of health.
Dr. Harris, that's a great point. I would hope in building F that we have made perhaps some space on the side to have perhaps a USUS community garden where we can even get all of our hands dirty as well, and then transfer that knowledge then back to if there's little people in our life or other people in our life that may not feel as comfortable with that sort of thing. But I certainly hear what you're saying. I think that's a great idea. I love it.
That definitely has come up for us too already. Could we do that even with what we already have at USU? But we'll just try it at Fort Belvoir. Dr. Harris, that's the next step. Olivia Walker, you've got your hand up.
Yes. Hi, how are you all doing?
Good.
I am absolutely delighted to see how you all are encouraging and moving forward with this. I remember when Dr. Wayne Jonas was here and there was a lot of emphasis on food as medicine. There have been so many things going on with the American Cancer Society, partnering with different hospitals around in the past, with Whole Foods Market coming, showing how to cook and what to cook, dealing with different types of diseases. In addition, I've seen some fantastic things down in Memphis where there is something called a church health center that collaborates with physicians and dentists and all right in the middle of the urban area. Mm-hmm. I found out about this, went to one of their workshops down there to show what they were doing in the community with the doctors and the folks who were at risk, to teach them. Once the doctors are very much aware of what is going on, which in this case, this was all started by a pastor who happened to be a physician. So he saw what was happening with the homeless. He saw what was happening with the poor. They had gardens, they had cooking classes. It was phenomenal. Right down there near St. Jude's, a medical center and all, it was just fabulous. So I think this is fantastic. We've got CHAMP and what they're doing with supplements and all of that. We certainly can add to that. For a number of years, I worked with something I called church community health links at my church, where I decided, as you were saying, you got to show people, you got to get their hands in it. A lot of people don't know any way to do things, quote unquote, in a healthy way that tastes great.
Right.
So you can't preach to them. You got to fix something really yummy that looks fantastic and that they're going to want to chow down, and then you tell them how healthy it is. I just think this is fantastic. And if you need anybody in your cheering, what did they used to call it? The peanut gallery or whatever. I'm here to cheer you on and help you do. Yeah, we've got a lot of people in this area who know about organic gardening and things like that. And we certainly got space around. And, I just am delighted to see this, and anything I can do to help from any way, please let me know. I applaud this. This is fantastic.
Well, I will take that enthusiasm, and I hope it generates some enthusiasm for these kinds of things, because I think the more the different ways we tackle these kinds of things, whether it's doing a community garden or, thinking about different ways we deliver this education when we're doing lectures, to try to make it more experiential, do a little homework. This is the perfect flipped classroom model. It's sort of what we've been doing, right? You cook first, then talk later, and that's it's really been some of the most fun. It'd be great to do it together, but it's also okay to do it at home, right? And then talk about the experience. So I know we're hitting 1 o'clock right now. So if maybe one last question, if there's anything that someone wants to say or share or talk about. Yeah, and so just, I think this is a helpful thing to end on. Dr. Ford, you're 100% right. So that's part of the reason we make a nod to the fact that there's just all of this interesting controversy around nutrition education and nutrition generally, nutrition principles. And I think we actually spent some time so when we had a little bit more time with the students, having them dissect actually the nutrition literature and looking at how to look at nutrition literature with a critical eye and look at how those studies are put together, because obviously it's pretty hard to control for all factors when it comes to what you're eating and what the outcome of what you're eating. And so trying to help them understand that kind of and sort out how strong are these studies, what is this really saying, and then going back to general principles. Yep, Dr. Chang, 100%. More teachable and doable for everybody. Well, we certainly appreciate your time, and Dr. Scott and I have had a terrific time putting this together, a terrific time delivering this material. Dr. Chang has been a close part of that team as well, and so we certainly hope to continue.
Well, thank you, Dr. Cimino and Dr. Scott. This was a great talk. So everyone, thank you for participating. Please don't forget to fill out evaluation to give feedback to Drs. Cimino and Scott. And our next Grand Rounds talk is gonna be on 10th of February. We're gonna be talking about health equity. So look out for email coming from me about that. So if there are no more questions, we're gonna be ending here. We have the video recorded, so we'll send out the recording with the next email.
Thank you, everyone.
Thank you.
Thank you.